Hello, everyone. It's a pleasure to be here, and I look forward to speaking with you today about managing addiction in offenders through court-mandated treatment. As you can see on the opening slide, I'm an assistant professor of psychiatry here at University of Massachusetts Medical School and part of the Systems and Psychosocial Advances Research Center. I'm also part of the Law and Psychiatry program. In part, this research comes from the goodwill of the people at the Massachusetts Center of Excellence for Specialty Courts, who have helped to make sure that this research occurs. So I very much appreciate that. And the pilot study that I'll be talking about is funded through the UMass Center for Clinical and Translational Sciences career award that I received to be able to do this work. So I want to thank all of those before we even begin. So we're going to talk about three broad areas today that are closely interconnected. We'll start out by looking at addiction in the criminal justice system at large. We will then talk specifically about drug treatment courts, and then I will tell you a bit more about a pilot research study that I've been doing that's examining quality of life, chronic conditions, and perceptions of addiction in drug treatment courts, which you'll see throughout the slides will be labeled as DTC or drug treatment courts. And then finally, we'll conclude with some summary slides and then have Q&A, and I'm very much looking forward to your questions and hopefully being able to answer them and to share the work that we've been doing over here. All right, so let's start at a point that I think most of us are very familiar with, and that is that addiction disproportionately affects individuals who are in the criminal justice system. This was a very large study that was conducted that looked at inmates throughout the United States, both in jails and in prisons, and found that up to 65% of those who were currently offenders or had been in the past were estimated to meet criteria for substance use disorder. And this would include alcohol and drugs. But this was a study back in 2010, and so it is likely that this number is higher now, as we'll talk about some differences and trends in the drug use epidemic. What we see when we look at the criminal justice system, and the reason that we have in part this very high rate of substance use disorders, is that there is a perpetual cycle of drug use. And I'll be focusing very much on drug use itself, but this also is quite true for alcohol use as well. In fact, there are more people with alcohol use disorders than there are with drug use disorders. But this work and that of most of drug courts does tend to look at drugs, illicit drugs themselves. Perpetual cycle of drug use, engaging in illicit behaviors in order to obtain those drugs or by using those drugs, and then being prosecuted, whether it's by being put on probation or being incarcerated. And then because individuals who are usually go through the criminal justice system don't receive proper treatment, as we'll learn in a second, they're going to continue using drugs and alcohol in the way that they had before they came into the system, in order to perpetuate sort of this cycle, this never-ending cycle. What we're hoping to do is we will be able to have some programs in place, including the programs that are already in existence, and to explore ways that we can stop this cycle. So it's not a surprise to anyone that there is an inherent relationship between addiction and drug use. According to a NIDA principles, NIDA is the National Institute of Drug Abuse, the main institute at National Institutes of Health that looks specifically at drug abuse research. Principles of drug abuse treatment for criminal justice population. It talks about how drug abuse is implicated in at least 3 different types of drug-related offenses, and I suspect this is not going to be unique to anyone when we talk about things like drug possession or sale, which might include things like drug distribution, but also going to be offenses that are related to drug abuse itself. So, for instance, engaging in stealing or driving under the influence. And finally, and we don't necessarily think about these, but there are many offenses that are related to lifestyle, that are also associated with addiction. So for instance, things like trespassing or engaging in conspiracy. And so if we look at it from this perspective, we see just how many drug-related offenses are actually existing in the population. This is from the Brookings Institute, but there are many variations of this graph, which is one that looks at how often or what percentage of of all offenses for which people are incarcerated come from drug offenses. So this one looks at data from 1993 to 2009. As I said, there are many versions of this and more recent ones, including from the Prison Policy Institute. And they all suggest pretty much the same thing, is that drug crimes are either the main offense for which people are incarcerated and imprisoned, or very close to it. And so we see a slight variation between incarceration and prisons, which is sort of the long-term incarceration facility versus jails, which is more short-term, or where individuals would be placed while they're awaiting trial. But nonetheless, we see that it's consistent across, for the most part, state and federal, and certainly helps to explain sort of why we're seeing this perpetual cycle of people going into prison for drug-related offenses. So if we know that addiction and criminal behavior are related, then we also know, based on research, that by reducing drug use, we're going to get increase in criminal activities. I should note that references are available. I'd be happy to email to whoever's interested. I'll have my email at the end of this presentation. So therefore, if we look at it from a purely public health stance, we should treat inmates for substance use disorders, in part for the purposes of public safety. At this point, we don't even think about sort of the benefits that we would get from treating individuals simply because that's sort of the right thing to do. We can think of it as a public safety piece. And there's an author, one of the researchers at National Institute of Drug Abuse, wrote this paper in JAMA, and the sentence comes from there that I think is very important. She says, not treating a drug-abusing offender is a missed opportunity to simultaneously improve both public health and safety. And that is because we would not necessarily just be treating the offender, but we would in many ways be saving society both costs and potential crimes that are associated with this drug use. I believe there was some data that showed that if we can get one drug offender for each individual who has engaged in drug-related crime, if we can get them to stop using drugs and as a result not engage in criminal activities, we would save something like $91,000 a year with just a single offender. But besides looking at the public safety issue, you also know that individuals who are involved with the criminal justice system are at an increased risk for death from overdose. And some of these statistics are quite shocking and are very troubling and sort of lead to the same conclusion, which is that we need to provide treatment for individuals who are involved with the criminal justice system. Let me just sort of share some of these. The first being nationwide, and this was a study that came out in 2007. So these numbers are likely to be much, much higher because this is before the opioid epidemic really hit. Offenders are 12 times more likely to die of drug overdoses in the first 2 months of release. The same study sort of stated differently, suggests that death from overdose was 129 times higher in the first 2 weeks after release from prison compared to the general population. And in Massachusetts, what we're seeing is that compared to other states, Massachusetts hit especially hard with this, with the opioid crisis, is that individuals are 55 times more likely to overdose than community members within the first 3 months of release. And now in some of the most recent studies, and these really depend very much by state. So I believe one of these studies was from Washington State, and there are also some international studies in here. The other study included was from Scotland that found that overdose is the leading cause of death in recently released offenders, with female offenders who were recently released being at a higher risk than men from dying of overdose from a very within a short period of time. So what's the reasoning behind this? Well, we know that individuals, before they go in, and if they have been using heroin or another opiate heavily, are going to increase their tolerance to the point where they're using higher and higher amounts. By the time they leave, their body is no longer able to deal with the same amount of drug in their system, and what they're likely to do is go back to using at the same levels at which point they left off. And they're also likely to go back to using with the same individuals who might have continued using in the same amounts that they had. So as a result, they're likely to go back to using these very high amounts of drugs that they were using before they left, and now no longer being able to tolerate it, and therefore potentially overdosing, and in some cases dying from this drug use. So we know all this, but we also know that despite these terrible statistics, despite the fact that we know that if we can decrease drug use, we can also improve public safety, most offenders who are incarcerated did not receive any substance use disorder treatment while they're incarcerated. Now, according to the National Center for Addictions and Substance Abuse report, which came out in 2010, and again, this is the survey that looks nationwide at all incarcerated individuals, or as many as they can gather data on, found that only 11% of those individuals who were incarcerated and who have a substance use disorder actually received any kind of treatment for addiction. And this really included a wide array of treatment, suggesting that for the most part, most individuals are actually not getting the type of treatment that they might need. So you might sort of know some of these. It's not surprising. There are very many barriers in place that prohibit and make it very difficult for individuals to receive treatment in the facility. Probably while they're incarcerated, probably one of the biggest things is that we need to have acceptance from corrections that treating addiction is something that is both beneficial to them and beneficial to the community, and it's not just there that's immediately going to benefit the offender. With time, I think there has been more and more acceptance about this, in part because there has been great education about just the enormous cost of addiction to society as a whole, the potential for overdose. So there has been a little bit more acceptance. So for instance, in Massachusetts, there are several jail facilities that are willing to allow individuals who are either about to be released very soon or are not going to be detained for a long time to be maintained on medication-assisted treatments, and I'll talk about those in a little bit. But it's also important to note that there's just not always the necessary resources, that even if there's acceptance from corrections and they're willing to have individuals come in and provide treatment, that treatment is not always going to be there. For instance, buprenorphine, one of the medication-assisted treatments, requires a special medication license in order to issue it. Methadone requires daily provision of it, and the medication that is commonly used and more accepted, Vivitrol, which is a shot that is given every 30 days, is in many ways very, very expensive, and there have been ways that people have gotten around it, but nonetheless, there are real barriers that we need to acknowledge, that even if there's full acceptance. So this sort of goes along with this line of inadequate infrastructure, and this may mean that a Suboxone provider is not around, or it's difficult for financial reasons to provide some of these others. And of course, there's also stigmatization. This is not unique to the criminal justice system, but because the activity itself of using drugs is oftentimes an illicit activity, there's an additional stigma of engaging in illicit activity, and therefore having to deal with the consequences of having the addiction for individuals who have engaged in this type of behavior, and understandably those who are responsible for their care may not want to provide them with access to treatment for what they believe to be illegal activities rather than a medical condition. And there's also a real problem about continuity of care. So let's say some of these individuals were to be started on some sort of treatment, whether it be medication-assisted treatment or access to AA groups that may meet in the local facility. Well, it doesn't mean that they're going to be able to continue getting this once they're out in the community. So it might require case managers or some sort of follow-up that is likely to be of some cost to the facility and also require particular expertise that is necessary in order to make those connections. There have been some studies done on this about the treatment that is being provided during incarceration, and what we know is that people are more likely to receive treatment in federal prisons than they are in local jails. To some degree, that's sort of understandable. Federal prisons are facilities where people are detained for a prolonged period of time. There's additional funds that are available from the federal government. Local jails, on the other hand, oftentimes lack many resources that they would need. The problem is that individuals who are in local jails are the ones most likely to be out in the community sooner, and therefore can probably benefit the most from having these types of services. You also should not necessarily let corrections or similar facilities off the hook too easily. There are a range of treatments that could be provided. So, for instance, holding AA or Narcotics Anonymous groups is something that is not of great cost, but there could be issues with security. There are now states, or there's only a single state out there that is providing medication-assisted treatment while people are incarcerated in all jails and prisons, and that's in Rhode Island. This is a new program. It's the first state that is doing this. And there are select facilities that do so, even in states where that's not the case. As I mentioned already, Massachusetts is one of those. So I've already referenced medication-assisted treatment several times. I'll talk about it a little bit more here. We know that it is the gold standard for treatment of opioid use disorders. There are essentially three broad types. The oldest and sort of one of the ones we're most familiar with is methadone. The second is Suboxone, and the third type is Vivitrol. They're all slightly different. I won't get into it here. But what we do know is that medication-assisted treatment should be used long-term, not short-term. In other words, they can't just be given for a couple of days and then the person is fine. Should be used long-term, as unsupervised discontinuation can lead to reluctance to engage in future treatment and produce severe and extended withdrawal symptoms. So what we've heard several times during our interviews with individuals who have been on medication-assisted treatment is that they're concerned about starting some of these, including methadone, because if they're arrested again, these are individuals who might be in and out of the criminal justice system, then they're going to be discontinued on methadone once they get to jail. And discontinuation from methadone is in some ways as bad, if not worse, than discontinuation from heroin. And as a result, they don't want to go on this treatment because they're so concerned they're not going to be able to receive this treatment. And despite these guidelines about treatment of opioid use disorders, correctional facilities, and in some cases, rightly so, concerned about potential for diversion. In other words, being given to individuals not for the purposes of not using heroin or dealing with their addiction, but in order to get high off, and it might be for the person who it's prescribed, or it might be diverted to others. There's a perception that is still in existence is that by providing some sort of medication-assisted treatment, one is substituting one addiction, heroin addiction, with an addiction to this prescribed medication. And as I already mentioned, there are real costs, and some of these have to do with infrastructure. Others have to do with real financial costs that are associated with this. And there are many, many other reasons. So there are real concerns about this. Problem is that most individuals who do require this and who would greatly benefit don't receive it. So I found the study sort of shocking because it did find that many of the U.S. prison systems reported, and this is self-reported by the facilities themselves, that they were offering methadone treatment to individuals. However, when you look closely at that, what you find is that more than half of them only did so for pregnant women. In other words, they're not really offering it to everyone. They're offering it just to a select population because they think that that is the population that would benefit the most from this. And only 14% offer buprenorphine. This doesn't even have to do with how often this is being given, but just that they offered it. As I mentioned, in recent years, there feels like there's a shift that is happening, and that is there's a willingness to offer medication-assisted treatment, especially as it gets closer to discharge. So maybe facilities aren't willing to give it throughout the entire incarceration period, but as individuals get close to leaving. In part, this has to do with what has become more common knowledge, and that is that addiction is not merely something that happens to the individual, but is actually a disease, a chronic disease that these individuals are likely to experience and be dealing with for a very, very long time. We already mentioned sort of the unique setup that Rhode Island has, and what they've seen is they've already seen a little bit of a drop in overdoses, with fewer percentages of recently released offenders overdosing since they've implemented this program. So let me just summarize what we've talked about thus far and go on to our next piece. So we know that even though individuals in the criminal justice system are a great need for addictions treatment, it's not readily available to them while they're incarcerated. Research suggests that there are effective interventions, and that there may be a trend towards increased acceptance by corrections of offering empirically-based treatments during incarceration. However, that's certainly not the case everywhere. So what are some other solutions if we're not going to be able to easily provide treatment to people while they're incarcerated? Well, one way to look at it is by trying to break that cycle of addiction and criminal justice involvement. The easiest way to do so, of course, is to provide substance use treatment right away when people first start to experience those symptoms. Another option, and one that we'll talk about today, is the option of drug treatment courts, which are specialty courts that are there for individuals who have substance use disorders and who have engaged in some sort of related criminal activity. And so you see here a whole bunch of red arrows suggesting these are the points when they can get rerouted out of this cycle into drug treatment courts. For those individuals who fail drug treatment courts, they're likely to go back to incarceration and go back to probation. Depending on the state, there are some differences between when drug treatment courts, when someone can be placed into a drug treatment court. They can technically be diverted out of the system before prosecution, but more commonly it occurs post-prosecution and sometimes post some period of incarceration while individuals await placement in a treatment facility. So drug treatment courts now go back a couple of decades. They originated in 1989 and they were developed to provide addictions treatment to criminal justice involved individuals with the specific intent of minimizing incarceration and reoffense rates. There are now more than 2,700 courts nationwide, and in Massachusetts we have 25 of these. We have 25 adult drug courts. We also have 2 family drug courts and I believe 6 juvenile drug courts. So in total, there's close to 40 different types of drug courts, but 25 of what we would talk as sort of a purely adult court. So as I've already mentioned, drug courts mandate offenders charged with drug-related offenses to drug and alcohol treatment in exchange for avoidance of jail and prison time. Speak about what usually happens in Massachusetts, and that is an individual is either pleads to some sort of an offense, or this occurs post-prosecution, or agrees to enter drug court while their case is being held. So they end up usually spending some time in prison while they're waiting for a rehabilitation facility. We found that a lot of the drug courts in Massachusetts would prefer to have the individuals go straight into some sort of a residential facility where they are able to be observed all the time and can receive intense treatments, and not necessarily something like day treatment or outpatient treatment. It's not the case for every person, but it is certainly more likely than not that they will go in this facility. Program lengths for drug courts range anywhere theoretically from 15 to 24 months. However, what we find is that oftentimes it's a lot more than that. Times it exceeds 3 years. So individuals are really going in for a fair bit of time where they're going to be observed during drug courts. Failure to complete the program results in an incarceration. That's usually the case. That doesn't necessarily have to be. It's really up to the discretion of the judge, and depending on what the deal was when the individual first signed up for drug court. What we found is sort of nationwide and around the state that individuals who choose to do drug treatment courts might end up being on probation and being supervised much longer period of time than they would were they just to take a guilty plea and a sentence. So just to show you sort of nationwide, it's not a very clear picture, I apologize for that. As you see, there's sort of many states that have a lot of drug courts, some states that have a few, but for the most part, they're really all around the country, including in Puerto Rico, and I believe there's one in Guam. So it's really something that is common throughout the nation. However, there are also some differences between them, and I'll speak to that in a little bit. So who ends up enrolling in drug courts? Well, usually it's an individual who has a history of drug and alcohol abuse, and there are some drug courts that will also take individuals who are just dealing with alcohol use disorder and who are accused of crimes that are somehow related to addiction. They generally tend to exclude people who have distribution charges or very serious felonies. However, that's not the case. There are many drug courts that will take felony offenders. There are actually felony drug courts around the country. The reason for distribution charges is because you obviously have individuals who are all suffering from substance use disorder, and you would not want someone whose primary charge that is. Having said that, there are still many courts that will take those with distribution charges. The idea being here is ideally what you'd want to aim to do is enroll individuals who are at high risk for reoffense. They're very likely to engage in this or another type of illicit criminal behavior again, and they have a very high need for treatment. So this is not someone who might experience some symptoms of addiction. This is someone who is really struggling with it very heavily and might be doing so for many years. There's some really interesting but very limited data on racial differences. We know that there are racial disparities, but as I note here, and I want to emphasize here, there's no great nationwide data set in existence about these. What we see is we're much more likely to have white offenders in drug courts than Black or Hispanic, and there could be a number of reasons. Some of these reasons are very similar to other reasons that we have racial discrepancies in the criminal justice system. And drug courts are diversionary programs. In other words, this is something that most people would prefer. So the idea being that you might have systematic prejudice in that you select out for individuals who are minority backgrounds, and therefore there are fewer individuals that are Black and Hispanic who are enrolled in these programs. It could be due to lack of standardization. I should note we don't have any of these answers. This is important research that needs to be done. There's also an important point of the general mistrust that minorities may have towards corrections and police officers and being on probation, and the idea that they're going to be on probation for a prolonged period of time and as a result choose not to enroll. And there's some research to suggest that there are real differences, real racial differences in drug use patterns, in that there could be greater use of heroin and opioid use disorders, which tends to be nowadays, especially in Massachusetts, the most common reason for being enrolled in drug court, in that there are fewer individuals who are Black and Hispanic using heroin than there are white. But we need much more research on this very important issue. So how are these drug courts organized? Well, we have standards. There's a National Association for Drug Court Professionals, which has developed best practice standards that courts that want certification must follow. I'll just mention a few of these. There's the idea that drug court will use some sort of incentive. So they will get something good in return for following the rules and attending drug court weekly, that there would be sanctions for using drugs, and these sanctions could include spending a night overnight in jail for having a positive urine toxicology screen, or it could be having to do community service. And then there are going to be therapeutic adjustments, because courts are going to recognize that stopping drug use is a very complicated process, and most individuals are going to relapse. Most courts are encouraged and try whenever possible to use complementary treatment and social support services. All courts probably conduct regular drug and alcohol testing, sort of the key feature of these, of general probation and other such programs. And most courts, certainly that are all courts that have NADCP certification, use multidisciplinary teams, which usually include a judge, probation officers, defense attorneys, clinicians, that all sit around and make decisions about what will be best for the individual in order to best manage their addiction. The largest change is sort of relevant to what we talked about earlier. It occurred in 2015 when NADCP, so this national organization, made it mandatory that courts have to allow the use of medication-assisted treatment. There was a lot of back and forth from the courts about this, and as a result of this, essentially all courts were told that they have to allow individuals to be on medication-assisted treatment. Now, there's a difference, of course, between allowing and encouraging and commonly using. So there are still courts that may, in theory, allow, but in practice, do not like when their individuals are on medication-assisted treatment. And just tell you a little bit about Massachusetts, we have a Center of Excellence for Specialty Courts, which provides certification to the courts that meet criteria, which are largely based on NADCP guidelines, and this is just a website for you to check out as a resource that might be of help. Excuse me. So what do we know about drug treatment courts as a program? Well, overall, we think that they're effective. Research has shown across multiple meta-analyses, and that's when you combine research across multiple studies, that drug treatment courts tend to decrease substance use disorders, likelihood of drug and alcohol relapse, and reoffending. However, and this is a very big however, attrition or dropout rates can be as high as 75%, with on average, and this is coming from these meta-analyses, only 49% of the individuals who start drug treatment courses actually completing them. Those who fail, understandably, are incarcerated, as I've mentioned before, and often must serve the full length of their original sentence. In other words, they may end up getting a lot more time after having done drug court than if they were to take a plea. And also, those who fail to complete the program also have higher rates of relapse and reoffense, again, going back to this issue of public safety and their own safety and well-being. So, what impacts drug treatment court attrition? Well, there has been some research in this area, but unfortunately, much of this research tends to contradict its own findings. So one will find that a particular factor does predict attrition or dropout, whereas another study will show that it doesn't. So I'll show you a list in 1 second. And not only have we not really been able to fully identify what those factors are, we also don't necessarily have any specific programs or methods to improve retention using some of these factors. This is a long list that you've seen before you. I'll just sort of point to a couple of these. Some are not really factors that we can help. So for instance, one study or a couple of studies have found that heroin use is a predictor of dropping out. Another found that cocaine and stimulant use is a predictor. Well, these are individuals that we most want in drug court. So using this as a screener to who should or should not be in drug court is not going to be helpful, because we don't want to screen out for individuals who are most in need. Also, there's those with extensive criminal history. Again, we don't want to screen out for things. And then there are comorbid psychiatric conditions. We know that psychiatric conditions commonly occur with individuals with substance use disorders. So by screening out for it, we're going to potentially disallow individuals who are most in need of this type of program from entering. So although it's helpful from a research stance, from a practical stance, this doesn't really give us much information about what we should do next. The drug treatment course can be an effective solution to reducing rates of drug use and recidivism. National and state guidelines exist to help to ensure some consistency and evidence-based implementation in program administration. But many individuals who start drug treatment course programs don't finish drug court and are back in the cycle of use and incarceration. So, what do I have to potentially offer to try to resolve this better? Well, we've proposed a research study, as I mentioned, that is being funded through the UMass Clinical and Translational Center that is proposing to look at health-related quality of life, social support, and self-efficacy as some of the driving factors for the attrition rates, and therefore to try to address drug and alcohol relapses. And the idea being, if we can select variables that we can actually alter and do something about. Here's a conceptual model of how I think this might work. So there are a number of factors, and these are just 3 that I think are important, but also ones that I think we can address. And the first and sort of the key piece being here is quality of life, so health-related quality of life. I'll tell you a little bit about why. We can look at disease-specific quality of life that is going to be specific to a particular disorder. And if we can do that, then we can try to provide the intervention of referring them to appropriate medical care, which is what particular disease is driving the issue of reduced quality of life, which I believe, and this is the study that is going to test that, that's driving down, increasing attrition from drug court. And there are a few other factors that I won't spend much time on here. So why is quality of life relevant? So I'll put all of these up here, and there are a number of reasons why. So first, quality of life is self-perceived physical and mental health and its effects on wellness and functioning. It's essentially, what is your well-being? In almost every other disorder, we know that is one of the best predictors of morbidity and mortality. We know that National Institute of Drug Abuse, FDA, the CDC have called for greater focus on quality of life and addiction, and yet that hasn't really been the case in drug treatment courts or as much in the criminal justice system. Perhaps most importantly, in many other disorders, we know that quality of life has been shown to predict treatment adherence. So how likely are you to remain in treatment from something like cancer to something like infectious diseases, so a wide range of these disorders. We could also measure it reliably, validly, and efficiently, which is a very important factor if we're going to try to do something about it. And finally, there's something called disease-specific quality of life, which is then going to allow us to identify actionable and individualized foci for treatment. So the overall goal of this study is to evaluate 75 drug treatment court participants who are enrolled in Massachusetts drug treatment courts at 3 time points. We're going to start out at time 1 within 4 months of enrollment, and then we'll do 6 to 9 months, and then 12 to 15 months. Participants will complete some semi-structured interviews and self-report measures. And we're going to do some mixed methods analyses, so looking at qualitative interviews as well as the impact of their self-reports. To date, what we've done is a pilot study of 30 participants from 2 drug courts, and we've administered a number of instruments, part 1 being the SF-36 and the QDIS. SF-36 is a measure of quality of life, and QDIS is disease-specific quality of life. We'll sort of look at what that looks like. Let me tell you a little bit about the demographics of this pilot study. They're predominantly male and also predominantly white, consistent with what I talked about before. The average age was about 36, ranged from 20 to 61, and many of the individuals had less than a high school diploma. Most were also unemployed, with only about a quarter working full-time. Something important to consider for a different talk is that most of these individuals have at some point been homeless or lived in a shelter at some point in their lives. Many have been arrested for violent offense, and the range of offenses for which they were arrested for which they were in drug court really range from something like violation of probation to assault, breaking and entering, really quite a wide variety. All of these individuals had extensive addictions treatment before, including about a third of them being on medication-assisted treatment, which is really good when we think about sort of the previous non-acceptance of medication-assisted treatment in courts. And 60% have at some point been on medication-assisted treatment. Most did identify opiate as drug of choice. Because we got such a range of individuals here, about a third of them did not currently meet criteria for substance use disorder, and they didn't meet it because they had received treatment within the past 12 months and therefore had not used within the past 12 months and no longer met current criteria, but all met past. Many of these actually had fairly adequate access to medical care. And as I've already sort of mentioned, we're going to look at some of those data. So chronic conditions, perhaps one of the most surprising things, though not something that once we start to think about what's really happening, is that about 3/4 of the individuals either currently had or in the past have had hepatitis C. And this number is incredibly high. So there are rates that can be as high as 30–40% in jails of hepatitis C. But something like this is really remarkable. It suggests that there's a concentration and a great need for hepatitis C treatment. What we've also seen is that most individuals had at minimum one of these chronic conditions, with almost a quarter having about 5 or more chronic conditions that they were dealing with. Actually, I'm not going to go through this other than to mention that looking at their quality of life, what we found was that on average, these individuals did better on their physical health scores than the population. However, when we looked at their mental health score, we found that they were doing worse than the general population. And some of the reasons for that could be that some of the conditions that they're dealing with are not necessarily impacting their quality of life. So when we looked at it closer, and this is why that disease-specific health-related quality of life is so important, we see that as we look across this, there are some diseases that really impacted, or chronic conditions that really impacted them, things like chronic back problems or clinical depression impacted them a lot more than something like hepatitis C. And again, it's important to keep in mind this is a small pilot study. Well, why is this important? Partly because we want to know how participants think about their disease, and if they don't think that this is something that impacts their quality of life, well, then they might not necessarily go and seek treatment for it. So follow-up topics that we're going to be exploring in research is looking at sort of hepatitis C virus and trying to understand how people in drug court receive treatment for it. The next piece that I'll quickly talk about is that individuals really saw addiction in different ways than we expect them, which is that we thought they were all going to, at least to some degree, agree that addiction was a disease. That actually wasn't the case. When we started asking people, we found that many thought addiction wasn't a disease or a chronic condition, and they gave some good explanations, some saying that it was hereditary and biological. Others told us, however, that addiction is a choice, especially relative to diseases like cancers. They say you don't have a choice of having cancer or diabetes, you have a choice to pick up a needle, as one participant said, and these are really fascinating quotes. Others talked about addiction starting out as a choice and later on becoming a disease. It's a disease to a point. The way I look at it is the second you stop using, it's the choice to go back out there. We also had lots of people talk about how much addiction is influenced by the environment. All depends on the environment you're around when you grow up. If your parents are addicts or they're just always around liquor, it gets in your mind, and then it's normal. And finally, we heard people talk about addiction as being socially constructed. I hate to even say this, but do you know how much money is in addiction facilities? And to be fair, this person is picking up on something. Sober houses, halfway houses, it's a exploitive market, okay? They're making more money putting us through this program than they are keeping us in jail. Realistically, it's all about money, and it's put as a disease to make money. Well, there's certainly arguable points there, but to some degree, this person is making a very significant observation about the financial aspect of the treatment world. So what we're going to try to do in subsequent research is to try to understand how these different perceptions impact the type of treatment that individuals are going to initiate and then retain it. In particular, if we're talking about medication-assisted treatment, then individuals who don't necessarily think about addiction as a disease may not necessarily be interested in starting or remaining on medication-assisted treatment. This is all for subsequent research that will be very important to do, and we're hoping to do so in the next couple of years. So I'll summarize this in that preliminary research suggests that even though drug treatment course participants deal with a range of chronic conditions, many of them do not impact their quality of life, as I mentioned with hepatitis C. Future research will examine the relationship between quality of life and initiation, retention, and treatment, and that is the research that we're doing now. Finally, drug treatment court probationers do not necessarily perceive addiction as a disease. Some do, and while some don't. This may have important implications for the type of treatment they will be willing to engage in, and that's for future research for us to address.